Good morning, everybody, and welcome to Gulf PCR in its first virtual meeting and hopefully its last virtual meeting. And next year we'll all be able to meet here in Dubai. This session is sponsored by Edwards Life Sciences and is entitled Transcatheter Valve-in-Valve Procedures Making Tomorrow Today. The objectives of the session will be to discuss the advantages of TAVI over surgery for valve-in-valve procedures, and it will touch on both TAVI valves within surgical valves and within previously implanted TAVI valve. We will also discuss the benefits of SAPIEN 3 over TAVI for valve-in-valve procedures as it relates to coronary access, and then review an excellent case that demonstrates simultaneously both a TAVI valve implanted in the surgical valve and at the same time within a previous TAVI valve. A fantastic case that will be presented by Dr. Tarantini. And we'll round off with a live discussion. Please put your questions on chat and we will try and answer as many of them as we can. It gives me great pleasure now to present the first speaker, Dr. Khaled Almerri.
Yeah, hi everybody. Thank you very much for inviting me to this interesting session. So today I'm going to talk about a procedure which is valve-in-valve that has been emerged as an alternative way to redo surgery. The procedure has been utilized increasingly lately, and it's now accounting for about 5% of all the TAVI implantations. I have no conflict of interest here. So if we talk about tissue valve failure or the need for valve replacement or redo valve replacement, the data that we have it from basically the surgical data. And if we look to the data from surgical papers, we find the rate of tissue valve failure account for up to 50% over 15 years. The problem with the data here is the number of patients in those trials is small. And the other thing, the patient who got the surgery are not the patient who really had their valve failed, but those patients who went for surgery. So patients who had failed valve and could not go for surgery because of their risk, because of their age, because they did not want to do that. So they were not included in those trials. But if we look to this big meta-analysis that included more than 50,000 patients, we found the rate of valve replacement, surgical redo, with that criteria that I just mentioned, only the patient who went for surgery at 10 years, 6% of the patient will have their valve intervened or reoperated upon. And from that time, within 5 years, the number doubles. And at 20 years, 50% of the patients will have their valves replaced. And if we look to the data from VIVID registry, we found some valves and some patients did better than others, but most of the valve got replacement around 8 to 9 years. And the importance of that comes into the rate of the usage of tissue valve recently that has been increased over the last couple of decades on both sides of the Atlantic. So if you look to the usage of tissue valves, it has been significantly increasing, and that's up to 2012. And I'm sure with the new data on the tissue valves or the TAVI valves, and low-risk patient, even that number will go even higher. So we are facing a group of patients that is increasingly or has been increasing over the last couple of decades. Not only that, even the guidelines has dropped the age criteria for tissue valve from an ACC from 65 to 50 years old, and the European guidelines dropped to 60 years old. The importance of that is if we start putting tissue valves in younger patients around 60 years, that we think those patients' life expectancy will be around 20 years. That means that those patients, most probably they will need an intervention at age of 70 and maybe at age of 80. So they most probably will need a valve-in-valve in their life and maybe a 2 valve-in-valve in their lives if they're lucky. If we look to the problem with the redo surgery, so if we compare it to the original AVR, we find all the complications associated with surgery is doubled if the patient goes with redo surgery. Mortality is increasing, stroke is increasing, pacemaker rate is high, everything is higher than the initial surgery. And if we compare the redo surgery to valve-in-valve procedures, most of the data here, we got it from retrospective trials that basically showed the stroke and mortality is the same in those group of patients. I want you to pay your attention to the group of patients in those trials. Maybe the stroke and mortality was the same, but the group of patients, they were not the same. In TAVI group, they were older, and the Euro score was higher in patients who went for valve-in-valve. But if we match those groups, TAVI, valve-in-valve groups, transcatheter valve-in-valve groups, to redo surgery, we find patients who went for valve-in-valve percutaneously, they had less mortality, less risk of pacemakers, less risk of blood transfusion. And over 5 years, patients who had valve-in-valve were having better survival compared to redo valve replacement. And if we look to the data from the trials that included valve-in-valve patients, we found the mortality is usually in the range of less than 5%, which is very acceptable range. Now we'll go to a different group of patients. We looked at patients who had redo and compared them to the original surgical procedures. Now we're going to talk about patients who had valve-in-valve and compare them to patients who had TAVR as to the native valve. And we think valve-in-valve is higher risk procedure, but basically if we compare those two groups, patients who had valve-in-valve had lower risk of mortality compared to initial TAVR procedure, less risk of stroke, less risk of heart failure. So if we look to the performance of SAPIEN XT, we find in partner 2 trials, we find it has a good result regarding stroke for the next 3 years from implantation, and the redo surgery was less than 2%. Aortic regurgitation was excellent immediately post-procedure and maintained over the next 3 years. The mean gradient was around 16 to 17, was maintained. It has not increased, and the mean and the effective orifice area was also maintained. The patient's well-being and symptoms was maintained over the 3 years. And if we compare SAPIEN 3 to SAPIEN XT, we find the SAPIEN 3 did even better. There was numerically better results compared to XT regarding stroke, life-threatening bleeding, and mortality, and significantly better result with SAPIEN 3 compared to XT regarding aortic regurgitation. Now we are using TAVI and valve-in-valve for younger patients and lower risk patients. So if we look to the low risk patients who had valve-in-valve with SAPIEN 3, we find no matter what's the risk of the patient, whether it's low risk, intermediate, or high risk, the patient, SAPIEN 3 did really well regarding mortality, and there was significant less mortality in all those 3 groups. And if we look at 30 days and 1 year mortality, we find the risk of death with SAPIEN 3 is extremely low. New pacemaker, interestingly, is even lower than what is being recorded or reported in native TAVRs. And again, if we look to all the groups of the patient who had SAPIEN 3, whether it is low risk patients, high risk, or intermediate, SAPIEN 3 did really well regarding the device success rate. Coronary obstruction is really low. Mortality, strokes are even impressively low, and pacemaker still impressively low. A new group of patients, that is valve-in-valve, which is the TAVI in transcatheter valve, we find the rate of Failure of transcatheter valve is extremely low, 0.22%. Mean failure rate was 6 to 8 years. The gradient was 13 millimeters. Coronary obstruction rate is low, and mortality at 3 years is 1.4. Three problems that we can face with valve-in-valve: coronary access problem, residual gradient coronary artery obstruction. If you look to the access problems, usually it happens with valves that high commissural level with supraannular leaflets, small cells of the frame, misalignment, and low coronary ostial height, and narrow sinotubular junction. And if we look to the valve-in-valve and a transcatheter valve, we find the best combination is the combination that give you a shorter neo-skirt, which is like SAPIEN and SAPIEN, or initial SAPIEN and self-expandable valve in SAPIEN. And again, the risk of coronary access problem, which makes it impossible, we can see it here, is better if you implant SAPIEN initially. And as I mentioned here, is the best combination is shorter valve like SAPIEN and SAPIEN, or you start at least with SAPIEN, then you put self-expandable valves. And regarding gradient, yes, there are higher gradients if we compare to the native TAVR, but the good news is that gradient is maintained over 3 years and basically below the 20 millimeters, which we are concerned about for patient to have patient prosthesis mismatch. And there's a trick to avoid that, which is to implant your TAVR valve into the native valve higher. So if you go with higher implantation, you can reduce that gradient. And finally, the valve-in-valve procedure has been emerging to the guidelines, a class 2A. Take-home message: valve-in-valve has becoming more frequent procedure. Serious complications associated with it can be reduced by proper planning. Valve-in-valve with SAPIEN-free is safe and has good outcome at 3 years, no matter what the risk of the patient. SAPIEN-3 did very well in high-risk, intermediate, and low-risk patients. Thank you very much.
Good morning, everyone, ladies and gentlemen. My name is Giuseppe Tarantini. I'm an interventional cardiologist. As you can see, my task today is to present a case that I've decided to entitle "The First Cut is the Deepest." The title is not so straightforward at this stage, but it will be during my presentation. This is my disclosure, and this is the clinical vignette. Female, 82 years old, chronic AFib, treated with anticoagulants, diabetes, peripheral vascular disease, and history of rheumatic heart disease. That was treated with a PTMC due to mitral stenosis 20 years ago, and about 12 years ago, the patient underwent surgical replacement of the mitral valve with St. Jude Epic 27 plus a De Vega annuloplasty plus a left atrial appendage exclusion. 9 years ago, the patient underwent also a TAVI transfemoral with a SAPIEN 23 for severe aortic stenosis plus a PCI of the left circumflex and the right coronary artery. The 2020 presentation admission in our hospital was because of worsening of dyspnea and heart failure. Here you can see the echo findings that revealed a severe degenerating aortic valve with an aortic valve area below 1 and a mean gradient of 50, and the mitral degeneration with surgical valve with a mean gradient of 11. Here you can see the cardiac cath that's confirmed the severe aortic stenosis with a mean gradient of 45 and area that is below 0.6 centimeters square, and a mitral valve area that is below 1 with a mean gradient of 12. Actually, we underwent to the pre-procedural assessment that include, of course, the CT scan, that shows that clearly that the coronary artery are totally spared by the struts of the first SAPIEN. You can see also that the valve was quite symmetrical, was not eccentric, was very well distributed without any oval shape. And on the right-hand side of my slide, you can see also the degree of the severe calcification, the level of the carrefour of the aorta, but actually the reference vessel diameter of the right femoral was about 9 millimeters, so quite reassuring. Again, a pre-procedural assessment by coronary angiography that showed up the clear, height of the coronary with respect of the struts of the SAPIEN. So this is the case summary. Female, octogenarian, low body mass index, STS score 9, that means intermediate to high surgical risk, diabetes, peripheral vascular disease, 2 valves, one is St. Jude epic or mitral position, and SAPIEN 23 in aortic position. So the heart team discussion. What were the points not in favor of surgery? So in case of surgery, we had to do a redo complex surgery that include 2 valves in a high STS patients and, actually with low body mass index and octogenarian. So actually the surgeon refused the patient, so we decided to move for TAVR, but actually also for TAVR, there are some caveats that we have to respect and to forecast also. The risk of patient prosthesis mismatch and the risk of coronary obstruction. And actually we have to think at the kind of total revolving that include 2 transcatheter revolving this patient. That means in aorta and in mitral position. So this is the procedural strategy that we decide to follow. Local anesthesia, we don't have the anesthesiology in the room. Double femoral artery access, angioguided access puncture, superstiff wire in a left ventricle, temporary pacing, direct SAPIEN implantation, valve optimization, that means that we need to check for expansion and residual gradient, and percutaneous closure, in this case was the MANTA. Actually, before moving ahead to the real case, it's important to share with all the attendees that the SAPIEN is the only valve that in Europe has the CE mark for TAVI in TAVI. Actually, this is true for transfemoral, transapical, transaortic approach, and for all the different sizes that we have for the SAPIEN systems. Actually, this is not true for the other contenders in the market, okay? Let's say Accurate, Sportico, Corvallo, etc. This is the case. We went with another SAPIEN 23 in the previous SAPIEN. We underwent with the same balloon with a post-dilatation 2 cc more, and the final gradient was more than acceptable. It was 7 millimeter of mercury, even though this approach was an intravalvular valve in another previous intraannular valve. Why we decided to go in this direction? Because actually you can see also during this orthography that you won't touch, you won't threat, you don't stay even in front of the 2 coronaries. And this is important. In general, when you look and foresee at the whole path of the patients with severe aortic stenosis. Actually, we assessed also by CT scan, again, the coronary, the fact that the coronary artery were completely patent and clear without any, cell that is in front of the artery. So the engagement, as you can see on the left-hand side, is really straightforward. And the distribution is quite symmetrical of the new SAPIEN in SAPIEN. Actually, 5 days later, we had to complete the revolving procedure in this patient, and we went transcatheter with another SAPIEN, in this case SAPIEN 326 valve, to fix also the mitral stenosis that was a previous, surgical valve St. Jude that is actually degenerated because of, and the clinical ground, the patient had a mitral stenosis. And here you can see by echo, the results without any paravalvular leak, and the final gradient was below 3 millimeters of mercury. So let's share a few thoughts about this case. The first one is the importance of the coronary access after TAVR in TAVR. And this is the reason why I select the title, the first cut is the deepest. That means the first selection, the valve that you do, is the most important in the whole path of the patients. Let's try to explain a little bit better. On the left-hand side, here you can see if you decide to go with a short valve like the SAPIEN, you won't have any issue with the coronary because you stay subcoronary. The way around, when you implant a valve that is taller with a wrist plane that is above the coronaries, you have to take care of another variable, very important variable, that is the valve to aorta distance. And in this case, what is important is to understand if you are above more than 2, ideally 4 millimeters. In that case, you might go, with another valve involved, but actually the coronary cannulation might be tricky. Not impossible, but tricky because you need to go aside the two struts of the TAVR in TAVR. On the contrary, when you have a valve, it is a supraannular valve, and you have a very narrow VTA, in this case, if you decide to go with another TAVR in TAVR, you will cause completely the possibility to have an access in the coronary artery. So the coronary access is totally unfeasible. Having said that, let's review together some evidences related to this point. The first one is from my group. This is an angio-based forecast, 137 patients that had, after the first TAV implantation, a selected coronary cannulation. And here, if you look at the likelihood to fully engage the coronary artery, if you have decided as a first choice to go with a short valve, that is the SAPIEN, the feasibility is about 70%. Actually, this is the opposite if you decide to go with taller valve, self-expandable valve, because it is undetermined and unfeasible. That in one word means that you might have an impaired coronary access is in about 70% of cases. These data are quite consistent and superimposable when you look at the CT-based forecast. This is the group of Azim that shows that in 76% of cases, when the first valve is supraannular, you might impair the coronary access. And actually, 2 days ago, this is a paper from the group of Ron Waxman, and again, in about 78% of the case, when you start first with a supraannular valve, you might impair and threat the coronary cannulation, selective coronary cannulation, in case of TAVR in TAVR. But let's go to the last report in this regard. And we have, this is not a forecast like the previous paper. Here we're talking about 14,500 patients that actually received a TAVR in TAVR. And this is a CT-based analysis. Here you can see that 2 interfering factors or impossibility to have coronary access in case of coronary valve first is above to the 80% of the cases. On the contrary, it is less than in 1/3 of the case, confirming all the results of all 4 previous groups. And the science is the reproducibility of a finding. And in this case, I can guarantee to you that it's very important the valve that you select at first attempt. So actually, we have to foresee 2 different scenarios. One is the older patient where the THV durability is longer than the life expectancy of the patient, so you won't have any problem. But when you deal with a younger patient, 73 years old, the life expectancy is 2 times the THV durability. So you have to think the whole sequence of this patient. You have to foresee a TAVR in TAVR and probably another TAVR in TAVR. So the first valve that you select, both surgical or the first transcatheter valve, matter a lot in terms of what is going to happen in this patient in terms of coronary access. And what I used to say is what is important is not the THV durability. What is important is the patient-centered lifetime strategy. That means we need to be accurate and not unselective when we decide which is the best valve, when we look at the whole path of the patient, both for surgery or for TAVI. This is my last slide, ladies and gentlemen, just to summarize everything. On the right-hand side, when you have the coronary takeoff that is very short and the SDJ junction is narrow and you have a younger patient, my suggestion is to go for surgery. Surgery, and you have to select the most appropriate surgical friendly, TAVI friendly valve, because you need to not go for mitral flow, for instance. You need to go for a valve that permits, when you have the second chance to go with the TAVR in SAVR, to not threat the coronary artery. But on the contrary, let's go on the left side of the slide. When you have a large STJ and you have a coronary height that is very tall, very high, so you're not scared, you're not frightened to the risk of impair the coronary access, you might select not surgery, a surgical valve, but you might go for a transcatheter valve. That might be a shorter one or a taller one. But actually, this decision matters a lot, because if you have decided to go for a shorter valve and you decide you have the need for a second TAVR, in TAVR you might go with a SAPIEN, and this is CE mark approved. You might go for a taller valve, self-expandable in a shorter valve. This is not CE mark approval, but you might go in this direction. But actually, the main issue is when you have decided for a taller valve as a first valve. In this case, you might go with the SAPIEN within, for instance, core valve, and this is CE mark approval, but the coronary cannulation might be tricky. But if you decide to go with another core valve or another supraannular valve in a previous supraannular valve, you have the highest risk of impairment of the coronary access. Thank you for your attention, ladies and gentlemen.
Thank you very much, Professor Tarantini, for outstanding discussion and an excellent demonstration of a valve-in-valve, not only in a surgical valve, but showed us a valve-in-valve in both a surgical valve and a previous TAVI valve. So that was fantastic. I have a few questions that have come from the audience who have been watching, and you sort of brushed over them going through your presentation, but maybe you could define them more clearly for the audience, as this has come from the audience. And the question is, what are the variables that you look for when planning a valve-in-valve procedure? So what screening tests do you do, and what exactly do you look for in those screening tests when you're doing a valve-in-valve procedure?
Okay, thank you. I think what is important is to fix two very pragmatic points. The first one is what is important is to make a CT scan, and during the CT scan you can review different parameters. The most important are, first of all, to look if you have implanted the self-expandable valve, to look at the skirt, if the asymmetric part of the skirt is in front of the coronary or not. The second point is to look at the height of the coronary. The third point is to look at the valve to aorta and the valve to coronary distances. Based on these on these 3 to 4 parameters, you can know exactly what might be the risk of coronary occlusion, and secondly, to select the type of valve that is most appropriate in that case.
Thank you very much. I have another question, and it's can be directed to either Professor Tarantini or Dr. Almerri, and it's again a question that we've fielded from our audience here, and that is related to patient prosthesis mismatch. This lady did have a small, size 23 SAPIEN valve, and the question is regarding valve fracturing. They would like to understand how and when to do a valve fracture. And that's obviously more surgical valve and not the transcatheter heart valve.
You want me to answer as first or after?
Sure. Go ahead. Go ahead.
Okay, so this is a very important question. So related to the valve fracture, when we talk about valve fracture, we talk about surgical valve and not TAVR, because what we can break is the stent of the surgical valve. The point is that not all surgical valve can be, cracked. So the very, early edition is a little bit more difficult than the latest. But actually, when you decide to go for a valve fracture, the most important tips in practice are, first of all, to select a balloon, they need to be exactly the size of the valve. For instance, if you have a 23 St. Jude valve or other valve, biological valve, in that case, not mechanical, I'm talking about biological valve, you have to select a balloon size that is similar to the size of the valve and not more than 2, maximum 3 millimeter of the inner diameter of the surgical valve. At that point, you have to go with a non-compliant balloon. And although the nominal value of pressure is 3 to 4, for instance, with a true balloon, you have to go up at least to 12 or 14 atmosphere. Otherwise, it's not possible to crack the valve that stay below. Actually, there is another point in favor of SAPIEN when you think of the cracking, the valve-in-valve cracking, because you know that there is a warning from the core valve Europe and worldwide that you don't have to post-dilate too hardly the core valve to avoid to injure the leaflets, the supraannular leaflets. So when you foresee the need of cracking, probably it's better to go with the SAPIEN that has in its own DNA the balloon, because to deliver the valve you have to go with the balloon. So on the contrary, there is a clear warning from the company that it's better to not inflate at very high pressure the core valve.
Okay, this question is again from the audience to Dr. Almerri specifically. And I directed to Dr. Almerri because he is familiar with the audience that we're speaking to and will be able to answer this in an appropriate fashion. And the question is this, a little bit controversial, and the person did not put his name, but the question is, would you completely advise against taller, self-expanding valves in valve-in-valve procedures for those who have coronary artery disease, or I'll expand on it, younger patients at the potential for developing coronary artery disease?
Well, just it's the same as the previous questions. I think it's a continuous discussion. I think there is no ideal valve. So each valve has its features and advantages and disadvantages. So when we talked about the patient's prosthesis mismatch, we should look into the individual patients. We know supraannular valves, they will have lower gradients if we put them valve-in-valve. So if this patient we have a concern about having patient prosthesis mismatch, maybe a supraannular valve, and it's been shown in the papers and studies, that they will have lower gradients in those patients. But again, you have also to consider the risk of coronary access. And if you need to fracture the valve, as Dr. Tarantini said, not only you may damage the leaflet, but when you balloon the self-expandable, it may dislodge. So it is a balance, and you have to consider individually, take it individually, patient to patient. But if you have the height of your coronaries, the sinuses are small or big, you have to look into those before you decide to put either tall valve or small valves. We know shorter valves will have better coronary access. We have taller valves, supraannulus will have lower gradient. So you have to balance the whole thing. So you tailor it to your patient. That's my advice.
This is a question that has just come in from Dr. Shukri Saif on the Eastern Province. All of us know Dr. Saif, and his question is as follows. Do we know the impact of making coronary access difficult in patients that are older, the age of 70, without any evidence of coronary disease when they come for their first TAVI? So he said, essentially the point he is making, how important is coronary reaccess in an older population who at the time of their first procedure did not have coronary disease?
Is it for me?
I think coronary access
it's open
should be
to either one.
I'll just continue the answer. So I think the coronary access should be considered in every single patient, old or young. Yeah, but we have to be more cautious with younger patients.
Great. This is a question from me, really, and it's directed to Dr. Tarantini, and he actually, I think, to a large part answered it through his presentation, but I'd just like for him to clarify it to the audience. As we move with TAVI in lower risk patients and much younger patients with a far greater life expectancy, I think we should be talking about a lifetime plan for the patient rather than just concentrating on the initial procedure we're doing. And would you like to clarify for us, in a young patient, what is his thought process as he plans this lifetime experience for the patient and not just concentrating on the initial procedure, which includes possibly surgery, followed by TAVI or vice versa? Dr. Tarantini, can you please explain your algorithm again to the audience?
Okay, thank you. This is really, I think, the most important points of this session. So I would like to thank you for this question. So first of all, sticking to the previous questions, I think it's important also for the audience to consider also when we deal about older patients, that's, the risk of the need for future coronary access is about 10% if we just look at the risk of ACS of the patient. And there is a nice paper from Rodesca Baus in this regard that has been recently confirmed. So we have about less than 20% of the case we need to re-engage the coronary artery, but actually the orientation of the first TAVI is very important, especially when you go with a self-expandable taller valve. This is not an issue when you go with SAPIEN, and this is a very important point to highlight. Related to your point, when you have a very young patient, that means actually between 70 and 80, because this is the, the segments that we have to consider in the next year when we, that's the S guidelines on heart valve disease are going to be completed and presented the next year. So the gray zone, that means that the heart team has to work hardly, is between 70 and 80, because after 80, the first choice is going to be the TAVI. So there is no discussion related to this point. Between 70 and 80, we have to think at the whole path of the patient. What means that if we decide to go, because we have a low takeoff of the coronary, you have a very narrow ST junction of the aorta, and you decided to go for surgery, during the heart team with the surgeon, you have to explain and to share with them the concept that they have to select a surgical prosthesis that is very TAVI friendly in the second attempt of the sequence. Because if they decide to go with mitral flow, that might compromise, the need of future TAVI, or they complicate the future TAVI because you need to go for basilica, you need to go for chimney, for other kind of situation. So the whole path means that whatever is the first decision need to take care of what is going to be in the next 10 years, 8 years after the degeneration of both potential TAVI, first TAVI, or potential first surgery, looking at the second reintervention that for sure is going to be TAVI. That is my algorithm.
Fantastic. I think I have one more question here just come in. I'd like to direct it to Dr. Merri, and it's from Dr. Chandra. And his question is, what precautions would you take to protect a patient at risk for coronary obstruction when you're planning a valve-in-valve procedure? So what patient is at risk for a coronary obstruction and you're planning a valve-in-valve procedures? What precautions do you take?
I think the first precaution is proper planning. So you evaluate his CT. If his coronary obstruction is high, you should think of surgery, because we know from the data that we have, people who get coronary obstruction and you cannot access those coronaries, the mortality rate is 100%. So if you obstruct a coronary artery during valve-in-valve and you cannot access the coronaries, the patient will die. So if the risk is high, and you should think of surgery. Other precautions is basically try to sometimes you put a guide into the coronary artery with a stent, a guide liner behind the stents. If the risk is you think you can obstruct it. Sometimes you do basilica, if you're familiar with that, and if the orientation of the valve, if it is a TAVI valve, the commissures are not in front of the coronary arteries, you try to do that and split the leaflet.
Thank you. I guess thank you for outlining the fact in our part of the world, patients are frequently young, and therefore we shouldn't be embarking on a potential valve-in-valve procedure with a very high risk of coronary obstruction in a relatively young patient who is at low risk for a redo operation. I think that is important. I don't believe anybody, and please correct me if I'm wrong, Dr. Merri, I don't know anybody, at least in Saudi, who is familiar, who has done the basilica procedure, and even the advanced operators who do basilica. It's not a simple procedure. It's not without its own risk of complications and potential pitfalls. Thank you very much. One further question here that, again, I think we have already answered, but I will ask it anyway. And this is not related to necessarily valve-in-valve procedures, but it's a question from the area, and it says, generally, the population in the Gulf is young. We frequently get patients coming to us in their 60s, and it's out there. They know that a transcatheter technology does exist, and they will frequently ask for a TAVI procedure. How should we approach those patients?
I can answer to this point. At least in Europe, we have to admit that for patients younger than 70 years old, we don't have robust data. We don't have data about the durability or even the first valve, because we have data up to 10 years, but actually below 70 years. And when we talk about 60 years, in the vast majority of cases, we have also a bicuspidity of these patients. And actually, all these points are in favor of surgery. Actually, we have implanted in Italy, TAVI in some patients that had previous radiation of the chest, other situations that get these patients extremely or prohibitive surgical risk. So you don't have any other chance to go rather than TAVI. In that case, you have to go with TAVI. But actually, we need to be very clear that when the patient is at low risk with bicuspidity or even tricuspidity, it's 60 years old, the heart team has to be very fair and to tell to the patient that actually in 2020, we have to choose the SAVR in that patient, because this is the direction. We cannot leave room for further discussion. We know that the patient preference is for minimally invasive, but we need to tell him that the degeneration of THV might be as short as 5 years. And that point is going to be a mess, because we don't have data in this regard.
Thank you very much, Professor Tarantini. We're running out of time here, so I think we'll go ahead with the take-home message for this session. Valve-in-valve is becoming a frequent procedure. It can be associated with significant complications, primarily coronary obstruction, but these can be mitigated by appropriate planning. Aortic valve-in-valve through transcatheter heart valves in surgical bioprosthesis appears as a safe alternative to redo surgery in the vast majority of cases, especially the elderly, with SAPIEN 3 showing a low-risk profile. This evidence contributed to grant the Edwards SAPIEN 3 valve with both aortic valve in THV and surgical valves, as well as mitral valve in surgical valve bioprosthesis indications in patients at higher or greater surgical risk. Considering the overall patient journey or the lifetime experience, valve durability and potential consequences of repeated procedure are crucial, especially when treating lower risk in younger patients. And again, the concept that Professor Tarantini pointed out, we have to develop from the outset a lifetime plan for the patient that includes considerations for both surgery and transcatheter heart procedures, and also not only that, but includes consideration of which surgical valve if we're going to go down the surgical route, and which transcatheter heart valve if we're going to go down the transcatheter heart valve route. And thank you all for attending this session. I hope you benefited as much as I did. Thank you very much.
Thank you. Bye-bye. Thank you.
Thank you very much.
Bye.